Hello, I'm Amanda Deming, and this is my case presentation. I am in my third year of NP, and I have about another year to go. This is my objectives of my case presentation. I didn't want to really say what the diagnosis was at first, but it's hard to without giving objectives first. So the purpose of this case presentation is to understand the signs and symptoms of RA, recognize diagnostic criteria for RA, understand treatment for RA. My interest in this is because there are about 10 other differential diagnoses that could potentially be other than RA, so I find it really interesting that all these similar diseases could be so different in terms of RA. So there's some definitive tests that can help diagnose RA versus the other differential diagnoses, such as osteoarthritis. So this is the patient. She is a 39-year-old African-American female. She works as an ER nurse, and she likes to be active. She likes to run and exercise and swim. She is here today because she quotes, "I hurt everywhere and everything. I am exhausted and fed up with the pain, and I need to figure out what's going on." Subjective. Patient has been dealing with pain everywhere for greater than 1 year. She states it seems to be getting worse than better. She feels the worst pain in the AM, complaints of joint and muscle pain both. She has been diagnosed with fibromyalgia in the past, but she did not feel like that was a correct diagnosis. And she is pretty health aware because she is a nurse, and she disagreed with that diagnosis. She also complains of weakness and stiffness. Her joints that hurt the most are her wrists and her feet. Occasionally her ankles bother her too. Pain has been affecting her daily activities that she enjoys. Past medical history includes gastroesophageal reflux disease, asthma, and chronic pain. Surgical history includes 2 C-sections, a lap chole. She denies use of alcohol, tobacco, and other illicit drugs. She has no known allergies. Her current meds include Prilosec for her GERD, ibuprofen for her pain as needed, Ventolin as needed for her asthma, and Singular for her asthma as well. There are a number of risk factors for RA, and they include the female sex, which some speculate this could be related to our hormones, that we're more likely to get RA. Onset is usually in the 3rd or 5th decade of life. Family history of RA or other autoimmune disorders increases your risk. Environmental exposures also increase your risk, such as smoking and being around smoke. And then also obesity increases your risk for RA. Looking at her systems subjectively, she reported weakness and fatigue but denied chills and fevers, denied cough, shortness of breath, denied chest pain, denied abdominal pain. Musculoskeletal, she did admit to joint pain, muscle stiffness, and joint stiffness. She denied any numbness or tingling. Her skin, she denied any rashes. Psych, she did report depressed mood but denied nervousness and anxiety. Depressed mood, she related to the pain that she's dealing with. GU, she had no sexual problems or dysuria. Objective, vital signs. Her blood pressure is slightly elevated, but not too concerning. 130/86, 96 heart rate, 16 respirators, 98% of room air, 98.2 temporal temperature. She is slightly overweight with a BMI of 26. She had her labs drawn 1 week ago because she saw us 1 week ago in the office. Her CRP and ESR were abnormal. Her RF factor, rheumatoid factor, was negative. Her anti-CCP was positive. Synovial fluid analysis was done, and it showed poor viscosity and greater than 10,000 white blood cells. Her CBC and CMP and hepatic were normal, unremarkable, and her UA was normal. CRP and ESR are tests that can be done to look at inflammation in the body, and then as well as the anti-CCP look at inflammation in the body as well. RF is the rheumatoid factor, and just because a person is negative on their RF factor does not mean they can't have RA. So people can be negative and positive with RA. If you are positive for RF, you are more likely to have severe symptoms of RA. Synovial fluid, her results are likely of RA due to the poor viscosity and the greater than 10,000 white blood cells. Upon physical exam, she's alert and oriented ×3, no acute distress. Head, ear, nose, and throat were all unremarkable. Cardiac-wise, she rate, rhythm, and were all regular. No murmurs, scallops, pulses, +2 throughout. No lower leg extremity edema. Lungs were clear. No distress. Musculoskeletal, her upper extremities at her bilateral wrists and finger joints were tender to the touch. There was limited range of motion in the wrists and they were swollen. She had reduced grip strength bilaterally. Lower, her bilateral phalangeal joints of her feet are tender to touch and swollen, as well as her bilateral tibia tibetalar joints, the ankle joints, were tender and swollen as well. She does have decreased range of motion in her feet. Lumbar spine was normal, no swelling or deformities found. Neural-wise, cranial nerves 1 through 12 were intact. Her gait's normal. Deep tendon reflexes are normal. GI, soft, non-distended, no masses, bowel sounds present in all 4 quadrants. Psych, she is depressed. And then skin, dry, warm, soft, no rashes. Diagnostics. We ordered a number of lab tests to help rule out what was going on with her. These are the following lab tests we ordered. Imaging. These are typical imaging that can be ordered. However, we did not order these yet because she is not advanced. She does not have any deformities in her fingers, hands, wrists, and feet yet. So we did not feel like it was necessary to do any imaging yet until we did lab studies. According to the American College of Rheumatology and the European League Against Rheumatism in 2010, this is the classification criteria for RA. So if you fall greater than 6, you are definitely considered to have RA. Differential diagnoses: Raynaud's phenomenon, fibromyalgia, Lyme disease, osteoarthritis, systemic lupus, scleroderma, polymyalgia rheumatica. Some signs and symptoms of RA include fatigue, weakness, malaise, anorexia, weight loss, joint and muscle pain, joint stiffness, especially joint stiffness that is worse in the morning. RA affects symmetrical joints. So it's on both sides of the body, for say both hands, both feet. Swollen and tender joints, rheumatoid nodules may be present, and deformities of joints are present as the disease progresses. Assessment and diagnosis. So based off her lab results and the criteria, she scored a 7 on the diagnostic criteria for RA. It's affected 4 to 10 of her small joints. She did have an abnormal CRP and ESR. It's been going on for greater than 6 weeks, and she had at least 1 low test positive of the CRP and ESR. We will refer patient to rheumatology for further workup and specialized treatment. The top picture, this is what the hands of an RA patient may look like if the disease is progressed. Early on, this is more of what the patient's hands and feet looked like. You can tell in between her joints at the fingers, they're swollen. That's what early RA looks like. Our treatment plan for this patient, the goal is remission and low disease activity. We want her to get back to her functional abilities and do her daily activities without having severe pain. We will treat for her RA symptoms while waiting for patient to get into the rheumatology appointment. We prescribed ibuprofen as she normally takes, continued that drug. We also ordered prednisone. Ibuprofen, NSAIDs, and oral steroids are the first line drug treatment for RA. So we will reassess her in a month to 2 weeks until she can get into the rheumatologist. Especially around here where we live, the rheumatology is very hard to get into. You may have to wait months. So until she can get in, we will manage her symptoms. So we will put her on the prednisone and ibuprofen first to see how that goes. We will also add Flexeril as she needs for bedtime to help with muscle pain. And then we also recommend a daily multivitamin and vitamin D and calcium because of the prednisone. If no improvements within 2 weeks to a month, we will add methotrexate to the patient's regimen while she's waiting for the rheumatologist. We also will recommend her to continue her physical activity and see her counselor for her psychological needs at this point because she is dealing with the chronic pain and it's been pretty depressing for her. Pharmacological therapy for RA, like I said, was NSAIDs, ibuprofen, glucocorticoids, prednisone, disease-modifying anti-rheumatics, methotrexate would be the next drug we could add on. Other anti-rheumatic drugs, cyclosporin, tetracyclines, gold sodium, and then other biological agents such as anti-tumor necrosis factor and IL-1 inhibitors, B-cell targeted therapies, etc. Non-pharmacological therapy includes physical therapy, occupational therapy, massage, chiropractic, acupuncture, psychological interventions, counseling, and meditation. I chose the research article by Clancy and Hasthorpe. It discussed the pathophysiology of RA. It also mentioned assessment and diagnosing of RA, and it touched on CRP, which we did test, and this tends to increase with people that have RA due to the anti-inflammatory cytokines that are triggered in response to inflammation. CRP levels should be monitored and help determine treatment of effectiveness or progression of the disease. So she may need often CRP blood levels if necessary. CRP levels are also related to predictors of cardiovascular disease. This is why RA patients are more at risk for cardiovascular disease, and also why RA is important to be treated because progressively it can cause premature death related to the inflammation. Life expectancy of RA patients is 5 to 10 years less than non-RA patients from the cardiovascular disease risk factors, specifically the CRP levels. Anemias are also associated with RA due to the chronic inflammation and bone marrow suppression. This research article helps support the patient's diagnosis of RA. For patient education for this patient, I would educate her on making sure she's taking the NSAIDs appropriately and taking them with milk or food, and to know the side effects such as GI upset or GI bleeds. She should also avoid alcohol and smoking while taking this drug, and she should avoid any other NSAIDs at this time. She should also be educated on the side effects of steroids, the prednisone. It can cause emotional changes in the beginning, increased appetite, weight gain, and insomnia. She should take the pill with food. She should try to stay away from people that are sick because it decreases your immunity, your immune system. Do not abruptly stop the drug either without the doctor's approval or letting the doctor know. She should report any worsening pain and stiffness to the provider right away. Early diagnosis diagnosis and aggressive treatment is important for RA to prevent permanent joint damage, impairments to daily life, and potential disability from disease and premature death. As I said, RA patients are more at risk for cardiovascular disease and premature death, so that is a main concern. Goals should be managing symptoms and preventing further damage, gaining back functional daily activities, and maintaining psychological well-being. So my questions for you are, do you agree with the diagnosis of RA? What other diagnoses do you think she could be experiencing? If she was diagnosed with fibromyalgia in the past, why wasn't her RA diagnosed back then as well? What was missing or something? Should she have any other tests ordered at this time while she's waiting for her rheumatology appointment? References, and you can access the research article right here via this link. Thank you.